and I'll pull up your and you know what to do. Just let me know when you'd like me to scroll up or down, but I'll turn things over to you now. Thank you. Oh, Robin, I'm sorry. I think you're still muted.
Sorry about that.
No worries.
We have a young man, 31 years old. He has a history of IV drug use from a very early age. He used heroin for about 10 years. Reports being clean for the last year. He doesn't use any alcohol or tobacco. He has admitted to some marijuana use, but says that's, as far as it's gone with his drug use now. I think that he's doing well socially. I think he's got a job and he has a good support system. I am a little bit concerned because he keeps disappearing off my radar for a little bit, and he's been a little bit difficult to reach. I think Mandy's tried to reach him for a few times over the last week, and so have I, and we've yet to find him. So it's like he'll disappear and then he comes back for a little while. So I'm a little bit concerned about that. But he knew when he came to me that he had hepatitis for a long time. He didn't know exactly how long, but he had it for a while. His comorbidities include just some reflux. I treated him for H. pylori here recently, and his follow-up on that was negative. Vitamin D deficiency, allergy. It's not anything that's too significant for his comorbidities. As far as his medications, he's on vitamin D replacement, lamotrigine, and Latuda, and lorazepam. Those are all for his bipolar, his psych provider does those. He is immune for hepatitis A. No, I'm sorry. We started vaccinations for Hep A, and he is immune to Hep B. His lab results, kidney function is normal. His liver enzymes are a little elevated, not terrible. AFRI score was 0.459. His child Charcot-Pugh class A, a score of 5, and his MELD score is 6. So this young man has 2 genotypes. He's the first one that I've seen that has 2 genotypes, type 3 and type 1A. Fibrosis stage F1, F2. And so if I can find him, I think that his best treatment is going to be probably either Maverick or Epclusa. And I wanted to make sure with you guys that since he has the two different genotypes, if there's anything different I need to be aware of or any follow-up testing afterwards. And if you feel like either of those medicines is appropriate.
Excellent. Thank you so much, Robin. We were able to hear you, but the audio was kind of going in and out there for a little bit, but I was able to hear you. But if anyone has any clarifying questions about the case, please let me know.
Hey, Robin and Kaylee. How long has he followed with you?
How long?
How long? Yeah. I mean, do you know him pretty well and he just keeps kind of disappearing, or did he just kind of recently establish?
He's been in and out probably the last 6 to 8 months.
Okay.
He'll come and then he disappears.
Do you know why? I mean, is it because his job or transportation, or do you know what the holdup is?
He's working every time I call.
Okay, fair enough. Fair enough. I guess I just was asking that because, if he's wanting to get treated, but it's just limitations because he's just trying to stay on top of, his job or not lose his job. I mean, I wouldn't necessarily hold back treatment as long as he's committed to taking it. And then, as long as he can make sure to follow up with labs and everything, then I would say, even if he can't necessarily come in and see you as frequently as you'd want him to, if it seems like it's more just because he can't get off work, I'd probably still treat him. Treat him. Does anybody else have questions or anything before we get into recommendation?
You've been able to read them too. You know,
Right.
and so I can't read.
I had one question.
Sure.
If that genotype report came out on a single blood test, or was that like looking back over his history and at one point he had genotype 1A and then at another point he had genotype 3? I was just curious, or did it come back at the same time and said he has both?
Yeah, it came back at the same time. The first time I did labs on him, so that's the first he'd ever heard of it too. He didn't know at that point that he had two genotypes.
Well, I don't know. I'm going to defer to Kaylee what the guidelines are. I can tell you what I've made up in the past with dual genotypes, but I tried to look on hcvguidelines.org to see if they address it, and they really don't. At least that anywhere I could find it quickly. And Kaylee, you're probably more aware than I am of if there's any recs or guidelines. Back before there was hcvguidelines.org, we would look at whatever the most pessimistic genotype is and pick therapy directed towards that one. And it sounds like what you did when you were choosing your pan-genotypic agents. So I'm proud of you. I think your logic was very sound. So I don't, from a logic standpoint, have any protest with what you're suggesting. But I would love I'm not sure if the guidelines tell us what to do. I know that in the past I've had luck treating these people if you sort of focus on the most pessimistic of the genotypes to treat. And it's a little easier now than it used to be, but
He went for a liver ultrasound in June just because of the fact that he has two genotypes and one being, 3. It's a little bit more ominous than one, but I hope that he'll go for that ultrasound. I think he will, but.
Yeah, I think I agree, Robin. I think that's important to snag that ultrasound on him as well. And just as Dr. Gilfus was saying, we used to have guidelines when we didn't have pan-genotypics, and we may have to kind of come up with a regimen that addressed both genotypes when we saw mixed. We don't see it super often, so it's kind of cool that you do have one that's got mixed genotypes, because it's about 2 to 10% of the I guess it was with what we can pick up on our assays that present as mixed. And so now that we have pan-genotypics, there's not any kind of dedicated guidance, because we would just treat it with the pan-genotypic agent, since it'll address both. So I would defer, because he's on some medications that look like there's some interactions. I think the Latuda potentially can interact with the Mavorite. And then the Epclusa would be with his omeprazole. And so, I would generally say Mavorite for 8 weeks, but I'll let Rachel talk on what the interaction is and if there need to be any dose or medicine adjustments, or if it's just kind of monitoring.
Sorry, I couldn't find my mute button there, or unmute, I guess. But yeah, Kaylee, you nailed it. Really, the interaction there is expected to be minor. So that concern, what it is that the Mavorite would increase the levels of the lurasidone or Latuda. So what you'd be looking at there would be some of the side effects related to high doses of the Latuda. So those are things like that CNS depression. Sometimes we worry about. It would be short course, so I'm not super worried about things like the extrapyramidal symptoms and dyslipidemias and stuff. I'd really be more worried about the metabolic stuff if you were doing this longer. So what we have usually done is just kind of counsel the patient on, watching that how sedated they feel with that CNS depression, and if they notice anything else. And that's really the main thing. Most people in my experience have tolerated it, not had too much of that depression, CNS depression. So we usually just do that counseling and monitor for the short course.
Thank you all so much for those recommendations. Any other feedback, comments about this case? And Robin, did you have any other questions based on some of the feedback that you got?
I don't think what I'm gathering is average. What do you have? Does anybody have any recommendations for follow-up on him? And will it make a difference since he does have genotype or two different genotypes? Will it make a difference in me doing any kind of follow-up testing?
I think, Robin, you've already addressed it. The biggest thing was just making sure you have a good sound fibrosis assessment. You've already got the fibro test, and fortunately, even though he does have mixed genotype with 3, and you stated that as well, that's the one we get most worried about, but he's had this infection for quite some time. His fibro test was optimistic. As long as his ultrasound doesn't show any concerning findings for either PHG or nodular contour, cirrhosis, anything that looks like kind of leaning towards a more pessimistic ultrasound, then you don't need to do any dedicated liver follow-up for him long term. As long as his liver enzymes normalize, during and after treatment, I would say, just check labs at treatment week 4, hepatic panel and hep C viral load. And then as long as those look stable, like I said, even if he can't get in necessarily to see you guys for follow-up at that time, we want to meet him where they're at. So if he's committed to taking the treatment and is committed to following up with you if anything changes in his life, or if he's having side effects, or anything from that standpoint. But as long as he can commit to getting the blood work and taking the medicine every day, maybe if Mandy can just kind of even just check in with him over the phone, set up like a quick phone meeting just to assess him for that, if he can't physically get into your office, and then just make sure he comes in for his SVR12 visit, and just make sure that he knows he has to get those labs, that those are super important to make sure he's cured. But there's not anything specific that you would need to follow because he's a mixed genotype, as long as his imaging findings are consistent with what his fibro test showed.
Okay. Hey, while we're on here, I just wanted to kind of touch base with everybody and see, generally speaking, what's everybody doing right now if they find that the patient does relapse? I have some patients that they've not been clean for that long, or they might have a relapse here there. And I mean, the way I think about it is, if we treat everybody, whether they're in active addiction or not, we're keeping them from spreading the disease to others. What's everybody else kind of doing if they feel like their patient might be using? Are you still treating, or are you waiting, or what's going on with everybody else?
I think that's a great assessment and a great approach, Robin. I'm right there on board with you. One of the goals is to reduce forward transmission, and so if you're treating them, if they're committed to engaging in their care with you despite relapses, I mean, this is going to be a chronic condition that they're following, or that they're going to be struggling with a lot of times. So, relapse is expected in the majority of our patients with substance use disorder. And so, if they feel like they're they want to use the opportunity to treat, they're still committed to getting their hep C treated, sometimes that's a bigger deal to them than the substance use. So I don't necessarily hold off on treatment, but that's after a pretty open and in-depth conversation with the patient on what their goals are, and how they're going to minimize their risk. So forward transmission if they lapse, or if they do relapse, talking about harm reduction, like not just not sharing needles, but possibly if they're going to relapse, or if that happens, smoking or snorting instead of shooting, and just kind of little things like that. Or at least if that happens, to be open with you, let you know about it, so that way you can make sure they have Narcan provided to them, make sure that they know how to reduce their risk of having complications, and just more so like being an open ear and a good resource for them, so that even if that happens, they feel comfortable coming to you about it. And I think that approach has been the best for me thus far, rather than saying, hey, you need to have 3 drug screens negative and a year of sobriety before we try to treat you, because that's not realistic. That's not going to keep people in care, and that's really our goal. So I'm right there with you, but I do, don't always offer treatment to people if they are an active addiction, just based on, if I really gauge how serious they are about their care and their follow-up. So it's kind of just individualized.
Thanks, Kaylee. Did anyone else have any feedback on Robin's question? Alrighty. Well, I guess that's the last case we had today. So if anyone has any questions or anything Hep C, HIV, Lyme disease related, you're welcome to bring it up and we can just have an open discussion about it. I'll just do a little echo pause here for you all to kind of think of some questions if you have any.
I didn't have a question, but Robin, I thought it was pretty cool. Just if you thought about it from this perspective on this fella, you're treating his hepatitis C, which can reduce his likelihood of lymphoma long term, and you treated his H. pylori, which can reduce his likelihood of lymphoma long term. So I thought that was pretty cool. You're like an oncologist.
Unfortunately, around here, we got to treat everything. So
That's a good point, John. I didn't even wouldn't have even thought about that. Another thing I was going to mention, Robin, because I just thought of it, but with the, do you offer PrEP at all? HIV, do you get anybody started on that?
I've had a couple of inquiries about that. I do have a couple. There's one guy in particular that I'm probably going to start him on that, but it's not something that I do regularly.
I think Dr. Feinberg, I think, has a didactic coming up in July, I want to say, or sometime in the second half about PrEP. But that's something else, that we should be offering for harm reduction to our patients with a history of substance use, even in the last 6 months, or active use as a means of HIV risk reduction. So that's something too, if you even have patients, since it's something that I think that we'd like more primary care to be doing, but it's not really happening for various reasons. But if you ever want to present a case from a PrEP standpoint too, we're happy to give recommendations and follow up and work through those also.
Okay.
Good memory, Kaylee. Yeah, we do have Dr. Feinberg presenting. I think it's September 14th on PrEP. So we'll also be sending out that updated curriculum for the second half of this year. Ideally, we're going to be sending them out on Monday. So you all should be kind of seeing what's upcoming as well. But yeah, no, thank you for that plug, Kaylee. We do have a really great lineup of topics coming up as well. But any other questions, comments from the group?
Since we were talking about PrEP, one of our people that's in active treatment now, he just started, is interested in taking PrEP. He asked for that together. So how long, is there a time limit he'll have to wait before he can take another to start that, or he's just going to be finishing up his Hep C treatment?
Yeah, that's a great question. Well, it depends what PrEP treatment that he's wanting to start. So we have injectables now and then oral PrEP. Injectable PrEP is great, but I will tell you from personal experience, since it's fairly new and it's very costly, it's a pretty lengthy prior authorization process right now. So if he's wanting to get started on PrEP soon, oral PrEP is going to be his best bet, I would state. At least to get them started. Ideally, all of our MAT patients, we would, at least want to offer PrEP to them in conjunction with their MAT treatment. So that's something I wish we could get, more providers in the state on board with. But yeah, if he's almost finished with his Hep C treatment, do you know what treatment he is taking by chance? Because there are some drug interactions with Hep C treatment and some of the HIV medications, which is essentially what PrEP is, but there's typically workarounds or just monitoring. And since it's such a short course, I don't believe that it'll really impact his Hep C treatment.
He's doing Maverick. He just got his medicine last week. So
Oh,
he's got a
okay.
little bit to go before he gets done. Yeah, that's why I was
Gotcha.
wondering how long do we have to wait? Because he was adamant about that when we were trying to get him treated for his Hep C, and I was like, we need to do one thing at a time.
Yeah, no, I gotcha. So yes, you could start, if he's on Maverick, you could start either Descovy or Truvada. If he's Medicaid, Descovy is going to be the preferred agent on Medicaid formulary. It's 1 tablet once a day. The concept is for HIV risk reduction. So he just takes it. It's like birth control, but for HIV prevention. So he just takes it daily. You'd have to get baseline HIV testing, typically within a week of when they start. And if there's any concern about HIV acute signs or symptoms or acute HIV exposure, then you'd want to make sure you get not just an HIV 4th generation antigen antibody screen, but also an HIV viral load at baseline. If there's symptoms consistent with acute HIV, you'd probably hold off for a month and repeat HIV testing. Because the biggest thing is you just don't want to start anybody on PrEP when they have HIV infection, or you're going to be giving them an incomplete treatment regimen and potentially inducing resistance. So the big thing is just making sure they're HIV negative. If he's not having any symptoms, he has an HIV test, you can go ahead and prescribe PrEP. I usually do it the same day. I'll see him get their testing and just tell him, hey, I'm going to write this for you, but just wait to pick it up until I've let you know your HIV test results are negative. I also tell them it takes 7 days for the medication. This is the oral regimen. It takes about 7 days. So similar to birth control, you don't start it and then all of a sudden it's still working, right away. So 7 days for them to have protection from HIV through rectal intercourse. Now, if the risk factor is injection drug use or vaginal risk exposure or sexual exposure, it takes longer than that. It's about 3 weeks or 21 days before the drug levels of the PrEP are in their system high enough to give adequate protection. So make sure they know that too. I mean, if he's on MAT, he hasn't had relapses, it's kind of just another safety mechanism, but and then you just monitor lab work every 3 months, do HIV screening every 3 months. If there's any sexual risk factor, you do STI screening every 3 months, and then monitor baseline kidney function, and then typically monitor it every 6 months. If there's any risk factors for renal disease, if it's like a young, healthy guy that's, just wanting his PrEP and Hep C treated and he's on MAT, you really can just monitor the renal function annually. So, and then the only other thing, which I'm sure you would have checked it if he's on Hep C treatment, but is just verifying Hep B status. If there's a Hep B co-infection, the treatments for PrEP, they include tenofovir, both of the oral regimens. And so you're essentially like treating a Hep B infection too. So if they decide they stop the PrEP, and then that can make their Hep B flared. So you just want to make sure that their Hep B status so that you don't accidentally induce a flare or when they decide to come off of PrEP. But it's really not that much additional management. It's just kind of getting, just getting comfortable with writing for it. But it's basically just testing for HIV every 3 months and making sure they're taking it. And that's it. The side effects are pretty tolerable. Sometimes some GI stuff in the beginning. People can get pretty gnarly GI side effects at first. They always go away. Sometimes they just last a few days. Sometimes it's a couple weeks or so, but they always go away. It's called startup syndrome. It's just their body getting used to the HIV prophylaxis. But those are kind of the main things. But yeah, you don't have to wait till he's finished with his Hep C treatment to get him started.
Okay, thank you. I was just wondering.
Yeah, no, thanks for the question, Mandy. And thank you, Kaylee, for that really great response. Any other questions, comments? All righty. Well, thank you again, Robin, for presenting the case, and Mandy as well. I know you guys work together, so the two of you, thank you so much for bringing another great case. Always sparks great discussion, and we so appreciate you guys presenting these cases. Big shout out to the hub members as well for always working so well with me and working on the curriculum and just making the session so wonderful with all this great information. So big shout out to you all and everyone else joining the sessions as well. Thank you guys for participating. The only announcement I have is that the next session will be on June 22nd. And Kaylee, I have you down for Hep B vaccination. So keep an eye out for that reminder. We're looking forward to that. And I'll be sending out the updated curriculum next week sometime. So if you have any questions about it, you're always welcome to email me, send in suggestions, whatever you might want to reach out to me about, you're always welcome to. So thank you all so much. We'll see you guys next time. Take care.